Today's session will be recorded, and I did mention that I'll also be sending out a document with several links to different quality education webinars that might be helpful, particularly if you're kind of new in your role to quality improvement or haven't developed quality improvement programs. And just a big thank you to everyone who's registered for those regional meetings that we're going to be hosting the 1st of March. If you haven't received your invitation or it was blocked in your email, why, shoot me an email or contact me, and I will be glad to get the registration link to you or get you registered for the program. Please chat in your questions as we go through today. And as always, thanks to Allie Orwig for helping support Zoom. Allie's there at the Indiana Rural Health Association. And we will turn then the presentation over to Kerry Dunning, our swing bed consultant, working with the State Office of Rural Health. So, Kerry, it's all yours.
Thank you. I appreciate it. So here's sort of the ground rules for today. I've put more information in this presentation than we'll literally go through in this call so that you would have some things to go back and discuss with your team. But I want to start out with why quality is important. And the first thing you need to know is you're the only group in all of skilled nursing, whether it's a PPS swing bed program or all the nursing homes in the country, and that's long-term care and skilled nursing, by the way, have quality measures they have to complete. So that really means probably your day is coming. Having said that, there are multiple ideas on what to measure quality. And so I have on this first slide, for instance, we do our own measurement because you have compliance and quality people in your facility, and you have quality meetings that you're already tracking things, perhaps like falls or something within not only your program, but within the hospital system itself. So defining quality, we have to look at whether we're going to look at input or outcomes. CMS tends to be very outcome oriented, but many of the hospitals, we need input measures for reasons we'll go through. Institute of Medicine has one, CMS has one, World Health Organization has another one. So it's defined in many, many ways, and it's really up to you at this point to figure out how you want to measure quality. What I'm going to suggest through the slides as we go forward really will be that we need to start using things that CMS has already identified as important for swing beds and skilled nursing in general. So we start out with, in a hospital bed, we are working with generally a population over 65. We are getting much older people in our swing bed programs now, and we're certainly getting people with more comorbidities. So we have changes, and then we have weakness and inability to function because they've been laying in a bed for a couple of days. Then we have functional impairment, and then we're looking at a risk of disability. And more importantly, what this setting is for is if we have a loss of independence, can they go home safely? And our job really is to look at trying to get as many people home safely as possible. You may remember from prior conversations that there are really only two reasons for skilled nursing. One is quality of life, and that's what ADLs have been based on. The ability to get out of bed, toilet yourself, be able to fix a meal yourself, walk throughout the house and so forth. And the other one is safety. So our job is to figure out how we're going to accomplish this and how we're going to measure it these days. So inputs are things that I'm not going to spend a lot of time on, but I think you as a facility need to go back through. And it's how our staffing levels impact our outcomes with our patients. What kind of patients we're getting. This almost gets into population health these days because each of our own regions, we have a particular age group or type of patient. We may have a mix of demographics that include a population that's more impaired for a variety of reasons. We find in farming areas, for instance, that people have physical impairments much earlier in life because it's a really heavy-duty job description. In the Deep South, where I'm from, we actually have a stroke belt and a heart attack belt and a diabetes belt, and those three belts cross each other pretty routinely. So these are structural definitions that you need to defend and define internally. So I'm going to leave this for you to do some homework with. But examples of things as structural measures I've given you here. So it's your facility size, your availability on a 24-hour basis, what kind of services you have available, or whether you are having to send out, or what you're sending out to tertiary relationships. Certainly staff turnover is a big issue when we're talking about skilled nursing, because acute is one way that we have to document, for instance, and swing bed is another. So again, structural messages I think you can work on internally. Then we get into process of care measures. And we are needing to track some of these, and I suspect many of these are tracked in your quality, either monthly or quarterly meetings, and you're required, for instance, any falls reported or injury in general. You may do things like the use of urinary catheters with UTI, because CMS has determined that we're overutilizing catheters for UTIs, and or that we should have determined that they were headed for a UTI before they got there. All sorts of things going on. So these are process of care measures that you may also already be working on. And then we get down into outcome measures. And as I said, this is really where CMS has spent most of its time trying to impact skilled nursing. So functional status change, we've talked some already, that we are moving away from the ADL language into functional gain language. If you hopefully have a copy of the swing bed MDS, remember I suggest you use it as a training tool. You certainly do not have to complete it at this time. The ADLs are section G of the MDS. The functional gain is GG. And right now we are scheduled for October of this year to remove section G, remove the ADL language totally. I'm still not sure we're going to make that October deadline because of a variety of reasons. But if they're moving away from it, that means you in your facility for swing patients need to move to the functional gain language. That means your therapists need to use that language. It means your nurses need to know that language, because we need to know how a patient is functioning 12 hours at night, as well as the hours during the day when nursing and therapy are working with a person. Depression, pain control, certainly patient satisfaction, family satisfaction surveys you may be using. But these are outcome measures that CMS looks at currently. So when we're doing quality tracking, if you look at that list on the left, that's what everybody but you is already doing. And we're getting about 12 more added this year. So there's quality measures that are attached to the MDS. There are internal things that we have to report to state and federal surveys, as you do. We have to, infections is a big one right now. I mean, I don't know if you've gotten the update, but certainly the coronavirus, CDC has been putting out things almost daily on it. By the way, I think we only have 12 cases in the U.S., if that makes you feel better for today. QAPI, which is the QAPI, which is as it looks for those of you in quality assurance and performance improvement. It's a very set system in skilled nursing. CASPER reports are part of the system that monitors the MDSs that are submitted. Nursing Home Compare, you're probably aware of, that's public, transparent information on all the nursing homes in your area. And they do it the same. There's a home health one also. 5-star, there's value-based purchasing, and then a quality reporting program. You don't have to do all that right now, but what we can learn from it is you're going to have to do some piece at some point. So from everything down below that state and federal survey level, what of those items would you like to begin with? What's important for your program is what we're going to look at. So CASPER, for instance, where we get quality measures, this is the whole list of things that are tracked on every patient. Every time an MDS is submitted, this information is submitted to the federal government. I've highlighted a couple of things here where CMS has said on surveys they think are more important. They pay more attention to them. So pressure ulcers, falls with a major injury in particular. Any assistance with ADLs, remember post-acute is supposed to be helping people get home. So if their ability to move independently has worsened, or they have not or have made improvements in function, all of those in red are areas that I think you probably need to consider, with the bottom three probably more global that you could begin with. When we look at a quality measure, for instance, so the percent of residents who receive an anti-spike med, then you'll see in the right how many times this is tracked by the federal government. So it's obviously on MDSs, it's on care planning. There are 2 F tags, which are the federal violations if a survey team finds you're not in compliance. I'm going to take you to that bottom of the list if you're not currently using a Dr. Beers list for understanding the contraindicated medications for elderly patients. I would suggest you get that. That's a standard that's used by the federal government. The current list, Dr. Beers, I think died maybe 4 or 5 years ago, but the current list even have substitute meds that could be used, and they also have the reasons why they shouldn't be used for anyone over 65. So it's a good list to work with your physicians on too. This goes into all the survey things. This is one of the sheets that I'm not going to spend any time on, but do know that you can be surveyed by the state and/or federal government. They're happening in all states right now for swing beds and for critical access swing beds. So this might help you get some basic information. The top paragraph gives you the federal regulation where to find the basic information on the compliance with this. And then QAPI, if you're not using it, I'm going to suggest maybe you look at this as a tool that you can use for measuring a particular topic. So let's say you want to track falls with major injury, which I hope you don't, but let's just say you're using that. Then there are tools inside of this. So if you go to QAPI and SNF and just do a general search on the internet, you will come up with the QAPI CMS site, and there are multiple tools. I've put 2 examples on here because one is just a simple layout of a plan of something that you want to track. And it goes through things that you can then take to your quality meeting that's hospital-wide, that's very specific to an issue you're tracking only for swing beds, or maybe swing beds in addition to what's being tracked in a hospital. So they have tools that are laid out like this that are very helpful, and they're electronic. And then I love this one. Actually, if you're married, if you have kids, this is a great one. Just say why 5 times, and you might get down to the bottom line of what's going on. But the 5 whys are: somebody's had a fall. First question is why? Well, because they felt weak. Well, why did they feel weak? And by the time you go through the 5 whys, we're trying to get to the root causes of it, so that we, meaning therapists and nurses and maybe respiratory therapists and certainly physicians, everybody involved. And I had pharmacy. A lot of falls come because of the number of medications people are on. If we add all this together, then this gives you a good tool to build out your care plan, as well as your quality tool that you maybe use to monitoring certain issues. QRP, which is the quality reporting program, as you can see, the first section that they're looking at is GG, which is the functional gain section. I'm going to again suggest strongly that you need to be looking at the MDS section GG. You need to pull that section out, and you need to be starting to use that language in your care plan. You need to have therapy starting to use that language to set short-term and long-term goals. The whole industry is moving over to this language from ADL language. That probably means some of your nursing documentation may have to be changed in your systems from ADL language to functional gain, but you need to move now if they're talking about removing ADL language by October, and we need to have some consistency. The more you can look like and act like a skilled nursing facility, the less likely that you will stand out as an oddity and have surveyors look deeper into your systems. There are some other things coming on right now. We're headed for a measure on facility readmissions. It's another area that I suggest strongly that you look at what I call the tuck-in calls, calling within 48 hours or 72 hours of somebody getting home, and then every 7 days until that 30-day period's up, trying to avoid rehospitalizations, trying to avoid unnecessary visits to the ED, and you need to have measures. By the way, long-term, all of this information will help you when you are trying to build relationships with tertiary hospitals, because they're going to know that you're trying to pay attention to things they're getting penalties on, even if you're not. So here's some things I put on a list that you can measure. You can check box what you're already doing. You can look at some, maybe that's something you want to do. So there's some statistical information on the left, and then there's certainly some care or outcome issues on the right. Again, this is not a list we'll go through today. It's certainly something we can discuss in March if you are attending any of those area meetings, if we need to do more detailed work. But it is a suggestion that you start looking at what's out there already for skilled instead of trying to recreate the wheel. We need to match up with the rest of your world. So I'm going to leave you as, what's your initiative? What ones do you have in place? What do you think you need to have in place? What do you need to look at? What do you need to talk to to your administration about. But I think this list is probably now up to you to move forward on. So Becky, what I really like to do is get to some questions I'm going to show you here that I have put references in there to the main measures that are already being used in skilled care, should you want to look up any further information too. So Becky, if people have questions, comments, concerns?
If you go back, I think it'd be helpful if you went back to slide 9 for this question. I think
okay.
I'm right. Yes. The items that are outlined in red, can you go into a little more detail as to specifics around what we may need to look for in these quality measures? And I think specifically kind of what the surveyors are looking for.
Right. So the top 4 there, the pressure ulcers and falls, are measures. How many, and it says high risk, and there is a formula inside of the MDS that will tell you how they define a high risk patient. So simply put, the non-clinical language, it's someone who already has some skin breakdown. It's somebody who may be the brittle diabetic, somebody who is bedridden. So they fall into that high risk, and they already have pressure ulcers. So it's a list of people that have pressure ulcers, and they're going to look at is your care plan and how you are taking care of to make sure that they do not worsen while you have them, or that we are working on healing, and by all definitions of healing a bed sore or a pressure ulcer. And the second one is if they've worsened while you've had them, then that's what the surveyors are going to key in on. So one, you'd want to make sure your care plan shows the risk of this patient from the time of admission to develop pressure ulcers. They're going to want to see what you have done to try and prevent them. Those are things like the mattresses and so forth, turn schedules if they're capable of turning, and then how you fulfilled working through your care plan so that you were actually doing what you were suggested. Falls, I'm sure all your hospitals keep lists of falls. Right now, fall with major injury, gosh, I didn't look at this before I got on. I think it's within, I won't even say, it's within 24 hours maybe that you have to report a fall with major injury to the state. I would look at your state guidelines for that anyway, because sometimes the states are tougher than the federal. But are we having falls in your program? And then what's causing them would be the major issue. And then again, how you have your care planned, people that are at high risk for falls. The bottom 3 are really more statistical sort of information, which is if, so let's say 90% of the admissions you have help, need for help with their ADL. We're going to have that at admission. That will be in your nursing assessment. That'll also be in a therapy eval and plan of care. But if they're getting help, and if we're trying to help let them do things for themselves, we have a lot of CNAs in nursing homes, for instance, where they have a lot of patients, and it's a whole lot easier to help somebody get dressed and then kind of patiently stand by and let them dress themselves. So they'll be looking for that. And then the ability to move and the function, as we've been talking about, are really high attention getters these days. They want to know that they're making progress while they're in your program. We've talked about already tracking what their needs are at night versus the daytime. The ability to walk at 9 a.m. is usually considerably different than 9 p.m. And do we have the documentation that shows that's going on at 9 and 10 and maybe 1 or 2 when they're getting up to go to the bathroom? We need to have clear documentation that supports that we're helping them with that, and that hopefully they're improving, or if they're not, why they can't improve at this point will be important to our discharge planning. Does that help, Vicki?
Yes, that helps. You've covered the next question just a little bit, but do you have any guidance on how to organize your quality data information so that things are readily available should an unexpected surveyor come in?
Well, yeah, so I think you're probably already doing some reporting to your hospital-wide quality. So I would start with those items and see what's going on with what your quality objectives are for hospital-wide. And if you're participating in that, then you want to make sure that data is available. So that would be your quality person that's keeping graphs or information, some kind of tally of the information. What you'd want to do is make sure that that's being divided out into swing bed information versus the rest of the hospital. So what you would present to a survey would be just the swing bed data. And then I think you need to figure out which of these issues might be important. So I'm going to go back and sort of harp on the rehospitalization. That may be something you're not doing right now. So tracking it, number one, which can be difficult if we're not calling patients, trying to figure out, but you can certainly do that if you are running some kind of report from those that are being admitted. And you'll have to talk to IT about developing a report like that, or you do it manually for a while. But basically, if we're calling them, we get a pretty good idea of who's coming back into the hospital. The other problem we have with the rehospital stuff, because you're not doing it and everybody else is, so an area hospital that's PPS may have somebody that's gone home from their swing bed program, but they're readmitted to a larger tertiary hospital. That smaller hospital may not know it, but both the small hospital and the tertiary hospital are going to be fined from that readmission. So they ultimately find it out. So there are systems in place that you can track that more specifically. But for now, if you're not tracking it, I would love for you to start looking at and trying to track those that you are discharging. So I think it's a matter of working with IT. I think it's working with your finance people, and it's also working with your quality people to see what's already in place.
Okay, thank you. The next question is, do you have any insight onto measures that may potentially be required to submit to QualityNet? So I think, go ahead.
I was going to say almost, there's so many of them that we didn't even, I mean, if you just look at the quality measures here, this is just one list. You know, the QRPs have another list. I mean, there's so many lists out there. There's not much left. And if you notice maybe the third slide from the end or fourth slide from the end, talking about the SNF readmission being the one that they're going to start seriously tracking going forward. So that's the only new one that I know of that's on the horizon at this point. But we're kind of behind the curve here in the sense that again, PPS swing bed programs on this one in particular, but most of them and all your nursing homes have been tracking this data for 5 to 10 years already. So that's why I'm suggesting instead of recreating the wheel, unless you have a very specific issue within your hospital. It's a really kind of odd example is I work with a hospital in northern New Mexico that all their admissions are black lung disease. Well, they've got a different set of quality measures than the rest of the country is going to have. But so anything like that, that's very extreme. But generally, if you will go and look at this list and certainly look at some of the other lists out there, start picking from these because these are things CMS is already very interested in paying attention to.
Okay, and that actually, I think, pretty well addresses the next question that came in is, are you recommending then the items that you've highlighted in red as those that you would recommend starting with?
Yep, I am. The top two, you probably, I would guess, particularly falls, you may already have a system-wide measure going on anyway, which is one reason I was looking at it. And certainly falls or falls with major injury cause setbacks and change our care plan, how we're going to get somebody home safely. If they're falling, we need to get to some root causes. The bottom three, I think, are ones that CMS is really honing in on right now, the change from ADL to functional gain. And those last two are functional gain type of questions. So yes, I would think these are good ones to get started with if you're not doing things already.
Okay. That is all of the questions that I've received. You're also more than welcome to unmute your line and jump in and ask a question too. So Kerry, just to give people an opportunity here, any other words of wisdom or any other CMS updates that have occurred recently that you want to make sure the group's aware of?
No, I think you guys know how to do the common sense. The coronavirus is the hot topic right now and will be because it isn't going to die out soon. I work with physicians in China that are sort of hinting at that it's much worse there than we know. So if you're going to get surveyed in the next month, they're going to want to know that you are looking for coronavirus, what you have in place. You have infection control in your facilities, so just make sure when you're talking about swing bed admissions that those policies are in place for your swing bed. I think that will be a hot topic. The rest of it, really, it's funny, in some states, the only thing they're hitting on right now for swing beds is the activity programming for patients. So you might look at your activities and how you're making things available. But that's it. It's a pretty straightforward list about how we're going to get people home safely at this point.
Okay. I'm not seeing any other questions. So if something does come up after the call, or you're working on your own quality of program and have questions, why send me an email to the address that's in the chat box, and I will work with Kerry and we will get an answer back to you. So appreciate everybody joining today and appreciate your words of wisdom, Kerry. It's always very helpful.
I'm glad to be on, and good luck for everybody. Bye-bye.
Thank you. Bye-bye.